And with this group, our next group of expert colleagues, we'll be talking about neglected viral and bacterial diseases. And the order of speakers will be a little bit different than what you have in your program. The first will be Kristy Murray, Associate Professor of Pediatrics at the National School of Tropical Medicine, right here at Baylor College of Medicine. Second will be Dr. Hal Margolis, Chief of the Dengue Branch at CDC. And third would be Dr. Sue Fisher-Hoch, Professor, Department of Epidemiology at Baylor College of Medicine. So, Kristy? Oh, there you are.
Okay, great. Okay, good afternoon. I'm delighted to be invited to come and speak today about some of the work that we've been doing here in Houston. I'm recently a new member of the School of Tropical Medicine. I was very thankful to Dr. Hotez and others who brought me on over here. I was at the University of Texas School of Public Health for almost 10 years and then just recently started this position in March. And I'm really excited about being in this group because it's going to help diversify a lot of the work that I've been doing predominantly on arboviral diseases, but then bring me more into where I was very interested in tropical medicine. So what I'm going to do is talk a bit about dengue virus and our concern for risk of emergence here in the Houston area. So dengue virus is a flavivirus. The flavivirus is actually a very large family of viruses. Other viruses in that family include West Nile virus, St. Louis encephalitis, yellow fever, and even hepatitis C. With dengue virus, there are 4 different serotypes, and they made it easy for us by calling them dengue virus serotypes 1, 2, 3, and 4. With these different serotypes, they can cause different forms of disease. Many individuals will actually end up being asymptomatic after they've been infected with the virus from the mosquito. But then you see about 30 to 40% of people develop dengue fever type illness, typically characterized by acute febrile illness, retroorbital pain, rash, and different symptoms. Dengue hemorrhagic fever is a much more severe form of illness. Many times people think that this occurs due to secondary exposure to a different serotype of dengue. And then some individuals can progress on to dengue shock syndrome, which is typically a fatal form of illness. With transmission, it is indirect transmission. In urban areas, you see mostly Aedes aegypti, Aedes albopictus transmission. Predominantly in Latin America, you're going to see Aedes aegypti. This is a mostly human feeder form of mosquito, and you'll see human-to-human transmission through the mosquito bite. You can also have a sylvatic cycle with non-human primates. So dengue is not something that is new to Texas. In 1922, we actually had a very large outbreak of dengue in the Galveston area. They estimated about 500,000 people along the U.S. Gulf Coast region were infected with the virus. And then in 1980 to 1999, there were 64 cases of disease reported in Texas. And in contrast, there were over 62,000 cases reported on the Mexican side of the border. In 1999, there was an outbreak that occurred in Laredo and Nuevo Laredo, and they did a seroprevalence study to look at the seroprevalence for dengue in those areas. In Laredo, on our side of the border, they found seroprevalence to be 23%, and in Nuevo Laredo, they found that it was 48%. With this study, they were able to show that they felt the reason why on the U.S. side of the border we had such decreased risk of transmission was because of our basic standard of housing and standard of living, that because we had a higher standard of living that people were less likely to become infected. In 2004, there was also a study done on the U.S.-Mexico border looking at Brownsville, Texas, and then Matamoros, Mexico. There was a pretty large outbreak that occurred at that time. And what they found was about 40% seroprevalence in Brownsville, Texas, versus 78% seroprevalence on the other side of the border. And we've done a similar study with Sue and Joe down in Brownsville with part of their study that they've been doing with the Hispanic population and found about the same seroprevalence. So seeing everything that was happening down on the border area, I became concerned about the risk for emergence here in Houston because of many different things. Basically felt like Houston was the perfect storm for dengue. Basically our proximity to these areas, also vast shipping, air and ship travel entry points. We have a very large population that's densely populated. We have Aedes aegypti and Aedes albopictus mosquitoes here. And then of course year-round survival of these mosquitoes. Finally, we were concerned about the fact that disease recognition might be low due to the fact that its reported cases would be passively reported through surveillance, and that we really don't have diagnostic testing available for physicians. So we conducted a study looking at cases of people who presented with arboviral-like illness who ended up testing negative for West Nile virus and St. Louis encephalitis. And we wanted to see if any of these individuals could have been potentially infected with dengue virus. So we had over 3,000 CSF and serum samples that we tested using first an IgM ELISA, and then later went back and looked at plaque reduction neutralization testing and PCR of these samples. For those we found positive, we ended up doing chart abstractions and interviews on those cases. What we found was that 47 cases had detectable IgM antibodies present. 38 or 81% of these were serum, and then we also found 9 that were in CSF. And if you have an IgM positive result in CSF, it's typically considered a confirmed infection. We also found that 2 subjects were PCR positive for dengue serotype 2. And then we looked at PRNTs. We did see 5 subjects positive by PRNT, mostly for serotype 2. But again, PRNT is more of a test that you would do in the convalescent phase of infection, and these were all acute samples that were collected. We were able to do chart abstractions on 42 of the positive cases and able to access 19 people for interviews. 18 of the individuals, when we looked at their charts, met the case definition of dengue fever, which is having the different aspects such as fever, retroorbital pain, rash, myalgias, arthralgias. And so we went back and looked at those cases specifically. Interestingly, because West Nile virus was, of course, rampant at that time, a lot of individuals had LPs performed. And what we ended up finding is that those who had an LP performed, 100% of them had high white cells present in the CSF. 56% of these individuals ended up being diagnosed with viral meningitis, and 11% ended up being diagnosed with viral encephalitis. So when we looked at these cases, we did have 2 cases that were fatal. One of them was a 92-year-old African-American female. She came in June of 2003 and pretty much coming in very acutely ill and unresponsive. They found that she had nuchal rigidity, high white cells in the CSF, an elevated protein, and altered mental status. They ended up diagnosing her with viral meningitis and encephalitis, and after her onset, she died in 10 days. What was interesting about this case is, one, she came from an incredibly poor area of Houston, the 5th Ward area, where a lot of these individuals have substandard housing and no air conditioning. Also, she had been bedridden for 2 years because she had had hip replacement surgery, and so she had no recent travel outside of the Houston area. Her CSF was positive for IgM antibodies, meaning that she was a confirmed case, and we believe that she was most likely a primary dengue virus infection, and that her illness ended up manifesting as encephalitis, which a very small percentage of people end up with that form of illness. Our other case was a 49-year-old female who had recently traveled from Mexico. She had actually become sick in Mexico before coming to the Houston area. She ended up being diagnosed with severe sepsis. She had anoxic brain injury, hepatic cirrhosis, and she did have DIC, so she did have hemorrhagic manifestations. She had a history of frequent travel to Mexico, and interestingly, looking through her entire chart, not once did any of the physicians on her case actually put dengue as a potential differential diagnosis for her illness. And so again, one of these things where we believe that dengue is happening, but it's just going unrecognized because a lot of our physicians who are treating these patients don't either understand, one, that it could be here in Houston, or understand the clinical picture that could lead them to believe that a person could have dengue. So we believe that she had dengue virus infection that progressed to dengue shock syndrome. This is our epidemic curve of our dengue IgM positive cases. So looking at this, for those of you as epidemiologists, we see that this nice epi curve in 2003 is very indicative of an outbreak that occurred here. And it looks like we also had sustained transmission occurring in 2004 and 2005. I did star the cases that had a clear history of travel to Mexico before they became ill, and this was our one fatal case here in July that was the traveler from Mexico. This here is the one case in June who was the African-American female who had died. So right at the beginning of the epi curve and what we believe was a locally acquired outbreak. So our travel histories, most of the individuals did not have a history of travel. We had 10 people who clearly confirmed that they had no history of travel in the 3 weeks before they got sick. Again, 2 people from Mexico, 1 who had history of travel to the Rio Grande Valley, but other areas where we do not believe that dengue is endemic. So in conclusion, basically we found that we had evidence of acute dengue virus infections in at least a subset of these cases with no history of travel. And that we believe that dengue could easily become endemic and epidemic in the southern U.S., even here in the Houston area, where we have a densely urban population and also Aedes aegypti and Aedes albopictus mosquitoes. And so basically, we need to do more active approach to dengue surveillance in this area and improve our ability to diagnose cases. Right now, we're still working on having local capacity for diagnosing dengue. But I think before we can even have that happening, we need to really educate our physicians on the fact that dengue could be here, how to recognize it clinically, and be able to refer cases if they suspect dengue in their patients. Okay. I'd like to thank many of the people who are actually here today, my partners at the local health departments, but the Harris County Health Department, Deanna, Carolyn, and then also I see Raouf Arafat from the City Health Department. So I'm really glad they were able to come here today because our local public health partners are critical in being able to be the linkage between community and research. And also my collaborators at the School of Public Health, UTMB, and then CDC. And then also PanBio helped us with the testing. Thanks.
I want to thank the organizers. This is a fascinating meeting, and you can see I was given a tough topic. I was told to take this perspective from a large public health agency, namely the CDC, which is where I'm back working again. And Kristy just gave you a wonderful overview of dengue, and so I didn't put any of that in my slide set. So what I'm going to try and do is tell you where I think we ought to be headed with this disease. One point I'll make, and this goes back to Peter's comments early on in terms of diseases of poverty. Dengue actually is not just a disease of poverty. Because of where these mosquitoes live, which tend to be urban areas, they actually came out of the tree holes in Africa and everywhere in Latin America. They live in places where there are populations, so they're both rich and poor, and so this is not just a disease of the poor. Now let me see if I can get this to work. Well, what's happened to dengue over several decades? Well, it's fallen into all these different baskets of, it's a viral disease, and it was the quintessential emerging infectious disease. It's sometimes considered a neglected tropical disease, though people in Mesoamerica will tell you it's not neglected here. We know a lot about it. It's vector-borne, but I think one of the game changers that's going to happen with dengue is it's going to become a vaccine-preventable disease, and that probably is going to change and is beginning to change how we look at it and move forward in terms of our approaches, both in terms of the basic science, the epi-science, and the public health. So what drives us at CDC? One, it's a domestic problem, as I'll point out, as you saw part of it here in Texas. It's also a global public health problem. It continues to expand geographically. These mosquitoes keep moving, people keep moving, and in fact, again, remember, this is the cycle is humans to mosquito back to human. The non-human primate is a very rare part of contributing to the disease cycle. So as asymptomatic people, again, as was pointed out, of which 75% of the infections are asymptomatic, as they move around and there are mosquitoes there, then the disease is transmitted. I'm going to talk about some of the new tools that are going to become available or becoming available now with pretty extensive studies. And the key, I think, is that we need data to be able to make evidence-based recommendations for the use of these tools. That includes vaccine, but there's also a lot going on, which I'm not going to talk much about, in terms of modifying the vector such that that may become a part of the prevention armamentarium. And so, you know, we at CDC are kind of looked at, yep, we've got the domestic part, but we're also looked at internationally. And so that, again, is part of our driver in terms of how our programs move forward. So dengue in the United States, you just heard part of it. It's sporadic in terms of some of the outbreaks along the U.S.-Mexico border. It's been in Hawaii with introductions from the Pacific and from Asia. Many of you heard about Key West, where it's still unclear whether it's endemic there, with probably an introduction a number of years ago. But one of the big ones are the international travelers. And the other part of the United States is that we have endemic disease. And so our disease in transmission in Puerto Rico and in the Virgin Islands and in American Samoa and in Republic of Marshall Islands looks just like it does in Asia, in Brazil, in anywhere else. So we get it both ways, and we see the whole spectrum of dengue in terms of its various aspects of epidemiology. But let me talk a little bit about travelers. So I'm going to kind of bring this to, you know, as I move you in and out of the Mesoamerica part and bring you back home here, as you just heard part of the home a minute ago. So we have a lot of travelers who go to dengue endemic parts of the world. And studies that were done a number of years ago in the Geosentinel surveillance system said, look, dengue is the leading cause of acute febrile illness in returning travelers, except those that come back from Africa. Now, dengue is in Africa, but there it's malaria. But everywhere else, it's dengue. So you as a travel clinic doc ought to be thinking dengue probably 1, 2, 3, and then start putting others in your differential diagnosis. Unfortunately, we only get about a couple hundred cases, maybe at the most 600 cases reported to CDC each year. And I'm going to talk about that in a minute. So this starts to drive home the issue of surveillance. But we went back and looked at diagnostic testing done in the United States over the last 4 years for dengue, most of which is done actually in large reference commercial labs, 14, 15, 16,000 tests done a year. So there are a lot of physicians thinking that people have dengue, 4,000 cases over diagnosed in 2010, but there were only about 10% of them reported to CDC. The other thing that's happened is that, yes, we've made dengue a nationally notifiable disease, so that kind of pushes people along in terms of presumably improving surveillance. So what are some of the changes that we think are needed? Well, the first is surveillance, and let's talk about the travelers. We need to improve, as you just heard in the last panel, clinical awareness and diagnosis. People come back with severe dengue. People die from dengue. Has been increase in hospitalizations over the last 7 years in the United States that have increased threefold for dengue amongst, these are all amongst travelers. I'm not talking about the endemic part of the United States. Case management. People don't know how to take care of dengue. You know, it's this self-limited acute febrile illness. It's flu-like. Well, I'll tell you, it can kill you, and it can kill you very quickly, and it can cause a lot of morbidity, and I'll talk about that in a minute. And we need this data to improve prevention, both for recommendations for travelers now, and then presumably as we move into a vaccine era. The other thing that we need a big change in is diagnostics, and there has been a lot of change. You know, how do you diagnose dengue? Well, you need an acute and a convalescent serum specimen. Well, that doesn't help you as a clinician. So there have been changes. There are now 2 FDA-approved tests, one molecular, one IgM, for diagnosis in the United States. And I put this map up here looking at underreporting of dengue in travelers Texas shows up there kind of in that lightish red, so it says it's kind of in the 50% underreporting, but actually over a 4-year period, there were only 150 cases of dengue recognized, supposedly recognized at the laboratory level in Texas. Now, for a state like this, and from everything else you just heard about it, to me it says there's a lot of under-recognition. So if we kind of put our prevention thing together with surveillance and education underpinning everything, the big thing has always been integrated vector control. Well, that doesn't work very well, and I think now there are a lot of studies that say we've got to rethink it. Vaccines are probably coming, so those are our 2 primary prevention areas. The other big side has been clinical management. In Puerto Rico, we found that clinicians actually didn't know how to take care of patients with dengue. We've now developed a course material. Yes, it will go e-learning live towards the end of this year, but we've trained about 12,000 physicians in Puerto Rico on how to manage dengue, and it's interesting, in an evaluation that's ongoing now, we've actually shown dramatic changes in practices as well as it looks like outcomes, and that's rare in terms of penetration of an effect of teaching. So what about the vaccines? I've mentioned it a lot. Here's the chart. What's happening? So you see up at the top, Sanofi Pasteur has a live attenuated dengue vaccine. These are all tetravalent vaccines. There are a number of other manufacturers and developers in the game right now, and these are the ones that are gone the furthest. Their vaccine has actually now just completed a efficacy trial in Thailand. Some of us will get to see the data. The coding will be unblinded in about a month, and we think there'll be data out in the fall. So that's all I can tell you, other than there were 4,000 children, high incidence, 3% dengue fever attack rate over the 3 years of the study. And there's now large phase 3 trials going on both in the Americas and in Asia. So we really do think that there will probably be dengue vaccines available within the next 3 to 5 years. These others are coming along, but I can tell you that in 2004, none of these had moved into clinical trial and had come off the bench. So there's been a tremendous amount of effort, and much of this stimulated by funding from the Bill and Melinda Gates Foundation. And so what are some things going on here? Again, trying to bring this back to Texas. There's actually funding that has gone into the Border Infectious Disease Program for enhanced surveillance for dengue along the border. We're trying to improve diagnostics, both in border states, so the 2 big ones being Texas and Arizona, and on the Mexican side. And these are just kind of underway, and be glad to talk about these later. But we need disease burden data. You know, you hear about the outbreaks, but what goes on in between? Dengue is a cyclical disease. So you'll see the outbreaks, but you need to know what's going on in between those epidemic cycles. The other thing that we've been doing is to try and determine the burden of dengue amongst travelers, at least in some of the states that have the largest number of cases. And Texas, again, is one that, just because of your population, your proximity to Mexico, and because I flew in from San Juan last night, you have a lot of people that go back and forth to Puerto Rico, where we have a lot of disease. And we know if we just look at what we see amongst travelers, almost 40% of the cases of travel-associated dengue in the U.S. come from Latin America. So again, there's plenty of reason to believe that you're seeing disease here. Is it recognized? Well, these are some of the things, there's money out and about now to try and help define that. So I think it's a change in dengue. There are going to be some tools that can change how we prevent this disease, but we need good data in order to make good recommendations. Thank you.
Good morning, and thank you very much for inviting me here. I think I make a little correction. I'm greatly honored to be told I belong to the Baylor College of Medicine. I'm afraid I don't. I belong to UT Health, School of Public Health, and I'm from the Brownsville campus right down on the border. Can you hear me properly? I've not got a very good voice. Is that okay? Anyway, I'm Sue Fisher-Hoch, and I've been working on the border now for 10 years, and I come from a background of neglected tropical diseases. And down in Texas, right down in Texas, as far as you can go, life looks a little bit different from the rest of the United States and very much more like the developing world. So we've been able to develop quite a large program with our background that gives us some new light on what we can probably do. But I want to start by changing the gear, changing the background completely to something I'm becoming more and more passionate about. I'm going to lift the corner of a carpet and bring out an extremely large elephant, probably the largest we have seen so far. These are neglected tropical diseases for sure, but they're non-communicable diseases. Now, these have recently become to the attention of the WHO, who put out a report in 2010, a very nice report, which if you're interested, you should look at. I'll show you some of the data from it quickly. But also, I want to point out this. Chronic diseases to cost how much by 2030? Where does this work? That's not working, I'm sorry. Okay. You didn't expect 47 trillion, did you? Some of you may have read this figure, 47 trillion, and I invite you to work out how many noughts that is. This is vast in terms of public health globally. Now, this was announced at the World Economic Forum. And the interesting thing about this is the World Economic Forum has only paid attention to disease once in the past. And that was in 2001, when it was mentioned in terms of, and discussed in terms of AIDS. And in fact, this is what led to the Global Fund to fight AIDS, TB, and malaria. So this is only the second time that the economists have really weighed into an infectious disease and said, yes, this is actually very important. So I want to talk about it a little bit and give you some very fresh data from where we work to show how important it is. This, as I apologize for this is one of those WHO graphs that is very difficult to read when you download it from their reports, and it's a pity they don't make them a little bit sharper, but I want to show you something very, very important here. These are the World Bank income levels: low income, low middle, upper middle, and high income. Down here, you've got deaths due to injuries, deaths due to non-communicable diseases, deaths due to all of these together. Communicable, that's every single infectious disease. That includes AIDS and TB. Maternal, perinatal, and nutritional diseases, all lumped together. If you look at it here, in this group here, low, low and middle, upper middle, high, you will see that in the low income, sure, infectious diseases are important, but that's also maternal child health and injuries. When you get to the low middle, the transitioning economies, those that can now go and maybe occasionally buy some food that they haven't grown themselves, who've moved to the urban centers where they can no longer go pick a banana from the tree, you will see this massive shift in non-communicable diseases being the cause of mortality, by far the biggest cause of mortality. And that is really part of this hemisphere as well as the rest of the world. But in this hemisphere, we see this pattern here, particularly upper middle, particularly in South America and Central America, certainly as the countries are rated, though they have lots and lots of pockets of these people. And here you will see the non-communicable diseases have really taken over. By the time we get to everybody in this room, watch out for diabetes, cardiovascular disease. This is what's going to kill you. So this is very important, and I think something we should be paying attention to. And I will take you to how this impacts infectious diseases. Well, we've been working in South Texas on TB and diabetes for some time, and I'll tell you that story in just a moment. New TB cases in the world and in Texas, you will see these, what I can only describe as a fatal overlap. Because what we have shown here, and this is data we got when we first arrived there, about 5,000 TB patients from the border and from both sides of the border. And when we looked at them by risk factors, we found startling there were two populations. This is the population you're used to. Most people with TB are young, they're drug addicts, they've got social problems, they're homeless. There's another little peak here of homeless elderly. But then we had another population. These were middle-aged, often women, with no other risk factors whatsoever.
And it turns out that in fact over 30% of the TB cases have diabetes as their primary risk. This has now been replicated in many, many countries: Taiwan, China, India. We've got some data from Pakistan, data from Saudi Arabia, data from Tanzania. This is now kind of everywhere. So what do we do with this data? We thought, well, let's go look somewhere else. So we went back to Karachi, where we worked for a long time. As you can see, we actually rolled up our sleeves and got dirty. And we set up a cohort like the one we have in South Texas. And in this cohort, we discovered a lot of things. And one of them was that 73% of the diabetes patients in the cohort, and there was plenty of diabetes, are untreated. Now, we see the same thing in South Texas. And here are some of our data. We have a cohort we've been collecting since 2004. It now numbers 2,600, extensively documented with a very, very large archive of serial specimens. And we've been also weighted these data. They're randomly selected and they're weighted to account for clustering. So we actually have prevalence estimates. And I was going to say earlier, if I could have asked a question, that we have these specimens where we could do prevalence estimates for some of these other diseases. But when we look using the 2010 definition at this population over the age of 18, 30.7% actually have diabetes. This is absolutely massive, and this fits the 2050 projections from CDC that everybody is kind of concerned about. We've actually got it now. We're there. We have got more disease of this kind of disease in this community than anybody else anticipates. Only 31% of these have insurance, and so most of this is untreated. Anyway, quickly, I'm going to show you some of the things we're doing with this. Using this cohort, one of our colleagues, Dr. Chu, has done some ancestral information markers analysis and shown that this population we thought was homogeneous is not homogeneous. If you look here, you will see that black dots, more or less in the middle, are our cohort. The purple ones, a Mexican-American pool of markers, showing that our cohort is pretty well Mexican-American. But these here are, let me get them right, are European, and these are Amerindian populations. These are African. So our population has got no African component, but interestingly, it has a spread across Amerindian and European. Now you say, well, we knew that. Now I can tell you we can actually quantify it. We can put a number on it for each individual and for the population. When we do this, we see that certain very important risk factors, such as insulin resistance, high triglycerides, and low HDL and in fact ALT, raised liver enzymes, associate with Amerindian ancestry. So that is one of the things we're pursuing, and this has relevance to some infectious diseases. One of these, and I don't know whether you can see this, could we put the lights off because it's very difficult to see. One of the other things we're doing is seeing how this chronic disease actually impacts infectious diseases. These are slides of, a little bit difficult to see, unstimulated neutrophils from, first of all, people with a normal HbA1c, glycosylated hemoglobin, people with a highly elevated HbA1c. Again, these are participants from the cohort. These are unstimulated, and these are stimulated with pneumococcal antigen. Pneumococcus is a big killer of diabetes patients, very important in the developing world too. And you'll see that the stimulation here in the normal individuals is what we would expect to see, but you get hyperstimulation in diabetes. And we see this in all the studies we're doing, that this chronic inflammatory state results in hyper-response to a whole number of things. And when we then look to see here, we've got, see, I can't read it too well here, the antioxidant responses to the infection are larger in diabetes than not diabetes. And the killing of the pneumococcus however, is much impaired in diabetes. So what you get is a massive response to an infection and failure to control it. And this parallels exactly what we've seen in tuberculosis. The tuberculosis patients have massive responses, but they do not control the infection. We've also shown that some diabetes actually downregulates gene expression that are critical for controlling infection. One of them is a CD28 antigen, which we all know is involved with the response to many infections. Another one is the HK2 hexokinase 2, which is important in macrophage killing of tuberculosis. So we're starting to get some mechanistic answers to why diabetes, in fact, is a very high risk for infections of all kinds. So that's quite a quick kind of smorgasbord of what we're doing, and why I think that we need to take a new look at infections against a different backdrop with some new ideas, and I think we will be able to move forward in that direction. Thank you.
Right. If the speakers will come back up to the table, just take some questions. Any questions? Yes, in the back, with the lady with the wrap. I sense your chill.
Hi, I'm Kathy Troisi from the University of Texas School of Public Health. Kristy, am I remembering correctly that you did a seroprevalence study, maybe it was for West Nile, in persons experiencing homelessness? Mm-hmm. And could you, have you looked at dengue in that, was it for West Nile? Have you looked at dengue?
Yes, we did a study. It was about, we had 534, thank you, homeless individuals here in the Houston area that we looked at. We found that seroprevalence for, this was right after our first couple years of transmission of West Nile in the Houston area. So the samples were collected in 2004, and we found that of those individuals, people who slept outdoors had 17% seroprevalence for West Nile, compared to 7% across the whole population of homeless. We did look at dengue in those individuals, looked at seroprevalence, because we looked at all the different flaviviruses that could potentially cross-react with West Nile. And with it, we found about 9% dengue positive, but a good proportion of our homeless individuals were veterans. And so we didn't know if it could be related to being veterans and just having, being positive. We couldn't really look at acute infection in any of those individuals. But we did find some other rickettsial diseases as well, and I still think it'd be nice to go back eventually and look at Chagas and leishmaniasis and other diseases that could be potentially a higher risk in that type of vulnerable population. So, yeah, thanks.
Dean Hotes.
So I actually have a lot of questions, but I'll try to control myself to two. So one question is for the panel. So assuming that the observation pans out, that we've had dengue outbreaks in Houston since 2003, is that a game changer? That's the question. And the reason, and the context is it a game changer in the sense that because now it's not just occurring among poor people, but these are neglected diseases are occurring among presumably better off people living in nice places. There's nothing like that that gets media attention. Mm-hmm. Should this be our antenna that we use to draw attention to the neglected disease problem, with the argument that it could be considered somewhat exploitative to do that? But the second question is
I would say taking advantage of an opportunity. That's what I'd say.
Right. Of course. And then the second part of that is it also a game changer because does it mean now that we have an expanding base of dengue type 2 in Texas and dengue type 1 in Florida, and do we have the risk that someday the two will meet in somewhere on the Gulf Coast of the United States? So we have two dengue types and therefore dengue hemorrhagic fever and dengue shock syndrome. Are we at risk for that in the Gulf Coast of the U.S.? And that's the other thing we need to make people aware of.
Well, let's actually go back in some old history. You know, dengue was highly endemic in the United States, 1800s, all the way up to Philadelphia. So actually, in the United States, geographic distribution has constricted. The dengue might be going on here endemically or reintroductions. I don't know. We need to find out. You know, we saw it in Key West. We saw it over several seasons. And I'll tell you that, unfortunately, the kind of surveillance that you need, so going back to what I said, that in most cases this is just an acute febrile illness, and so it overlaps with influenza, overlaps with many other diseases. You have to look for it in order to find it. Even in the places where they know they have it, they really miss the burden. So we've got to improve surveillance. And then, to me, it gets to disease burden. It gets to, if we've got a good prevention agent, which presumably we will with vaccine, and it's, yeah, do you make a recommendation? Do you use it in Key West area? Do you use it here? There's actually a study getting started in Miami-Dade County right now to do just that, to look, because all the clinicians say, oh, we see dengue all the time. Do they send in specimens? No. Do they try and diagnose it? No. Well, we're going to try and change that. So I would say we need to get the data. And then, you know, the weight of the information can become the game changer. This business about, you know, severe disease and what are all the determinants, yes, second and third infections and maybe the order in which you get infections adds risk. But we actually don't know, are you only seeing dengue 2 circulating here and only, well, we do know, at least so far in Key West, it's only been dengue 1. But introductions come easily in these areas. So I don't think you have to worry about it moving across the southern coast to see potential worsening of disease. Let's just find out if we have it. And I think that's my message to everybody.
And if I can say, the reason that my interest in looking at dengue in the Houston area was because of my next door neighbor in West University, which is a very affluent area in Houston, considering the rest of the demographics here. And he told me that he had dengue virus infection in 1999. And I remember at the time, are you sure it was dengue? You know, was really, and he said he had no history of travel or anything, but that's what his doctor had diagnosed him as. I went back with a friend of mine who happens to be at the zoonosis control group with the Texas Department of Health, and went back, this person's name was not on any list of any reported dengue case in the Houston area. And so it started, okay, it could be recognized by a physician, perhaps they'll test with a reference laboratory, but then that doesn't end up getting reported to public health. And then also, too, that dengue is something that, again, it looks like any kind of acute febrile disease. It's not something that has a classic presentation, so much so that we would say, oh my gosh, there's a dengue outbreak going on right now. That's why I thought it'd be interesting to look at these individuals who had either a viral meningitis or encephalitis type of picture. So when we look at what happened in Houston in 2003, these are only individuals that had samples submitted because the physician suspected West Nile. And so if we think about those being more the tip of the iceberg, and especially since we saw no geographic clustering of those cases, we would imagine that the actual infections that occurred during that year was quite high. So.
Let me just add on. It's not Texas, it's Florida, but the Floridians have gotten quite acutely aware of dengue now. As I say, clinicians, health department. So last year they reported, I think it was 16 or 19 locally acquired cases of dengue, going up as high as Orlando, for which they couldn't find other sources. Now again, not intensive workups, actually 3 different dengue serotypes. So again, when you start looking, even with just a little bit of extra look, you suddenly start finding things, and that's been the experience in Florida.
Other question? Can we go over on this side here? I like the thread of the multiple partnerships that you're all referencing, the local, the county, the state, and this national. I mean, it serves to remind all of us that none of us does this alone. This woman right here in the front. Sorry.
Thank you. My name is Sophie Benedict. I'm a medical doctor working with ExxonMobil here. And it's been a good presentation. I've learned a lot from the talk about dengue and TB and diabetes. That's a new one for me. I know everybody talks about TB and HIV, but diabetes is not something that is pushed to the forefront when we talk about the risk factors for tuberculosis. And what I'm getting from that is that when you get a case with latent TB, you need to look out for diabetes. And my question really is more towards dengue. I know many years ago, diagnosing malaria here wasn't a big thing. But now that we have dengue, is there any plan to do more like a training or education for the clinicians so that they become more aware of what they need to look out for in terms of diagnosis? Is there any plan by the school to sort of do some kind of trainings and education for the clinicians in the American area? Thank you.
Well, since this information came to light with the study, again, this was done with the local public health partners, and it actually couldn't have been done without local public health. And so we meet, and we're about to actually meet tomorrow again, and we have these working group meetings to address exactly that issue. So one, how can we educate physicians? Well, before we educate them and get them to submit samples for testing, we need to make sure we have a good diagnostic scheme in place so that we can diagnose these cases. Right now, our local testing is still needing to be developed so that if samples are submitted, we can do PCR on these individuals, we can do IgM on them. And then that way, when we go to the medical community, we can say, okay, if you see a case of acute febrile illness, especially if they have what we consider classic signs such as retroorbital pain and rash, that those samples then need to be submitted to the local public health department laboratory so that they can be tested for dengue virus. And so all these things are needing to play out still, but our hope is that very quickly we're going to have this in place so that that way we can go to the physicians, tell them how to recognize the disease, and then also facilitate testing of individuals that they suspect is having dengue.
I'll also make a plug for ASTMH offers an update course in clinical tropical medicine in October. A very comprehensive 2-day course that has some of the nation's leading experts on exactly what you're talking about. I'll make sure you get the information.
I want to ask a couple of questions, a question to Dr. Margolis, but start with a comment. If you recall back in the ancient days when Aedes albopictus was found in tires coming from Asia, there was the great concern about suddenly we were going to have dengue outbreaks all over because we had these tires full of Asian mosquitoes, and it went up to Congress and money was obtained, and nothing happened. That is to say, nothing really occurred that carried out those fears. And so it seems to me that when we're talking about dengue or many of these other things, we really have to do a better job of having good, solid, hard data so that we can really have a better idea of what to predict, because we can't cry wolf too many times. Mm-hmm. People are not going to listen. And so what should we do in terms of dengue that would really provide the solid data, and who's going to do that?
So you set me up. Well, let's go back to the first part about solid data and don't overcall it. And again, for some people who know me from my viral hepatitis days and actually South Texas and the Colonias, and I think we very effectively went in there and with a good vaccine got rid of a disease, namely hepatitis A, because we had good data. And I think we have to use those same approaches for dengue. So let's get the data. You know, dengue's a lot harder. As I think we've all pointed out, it's difficult. I think there are now good diagnostic testing algorithms available. They can be done in any lab, be it public health lab, private lab, university lab. I don't care where it is. And that was one of our things. And this FDA test for the molecular side I mentioned just got approved last week. So, you know, this has been a year and a half in coming to do exactly all the regulatory things you've got to do, and yeah, we're going to put out information on, you know, what's a best testing algorithm, but then use it to interpret it and go forward realistically. As I say, no, the whole U.S. isn't going to need dengue vaccine, but boy, there's going to be a lot of travelers that are going to need it. We may need it on the border. We may need it, you know, in Florida, because again, the vector side is still quite a ways in coming in terms of better control. And I think we have to be realistic. Aedes albopictus turns out not to be as an efficient a transmitter for lots of reasons. But in places like, you say, why South Florida? Well, South Florida has predominantly Aedes aegypti. In fact, the whole Monroe County, which is Key West area, is only Aedes aegypti. So that's why they've had so much transmission. So we got to start putting our science together for good public policy.
And I would add to that, along with the good science, make friends with your local media and make friends with your elected officials' offices so that they are kept abreast of these new things that we are doing on behalf of their constituents. Of course, they're always concerned about their constituents. So I think with that, we are going to wrap it up for lunch. I believe that most of our speakers, if not all, are still going to be here with us through lunch and through the rest of the program, so you'll have a chance to chat with them. Lunch is being served directly in the room in behind us, and we will start promptly at 1 o'clock with our lunchtime plenary lecture from Dr. Andrus. Thank you.